Dr. Pearlz, Clinical Rounds here with a clinical case. Let's get right into it. 41-year-old female presents with the complaint of right-sided facial pressure and pain. Patient states symptoms began 7 days ago with a runny nose, sore throat, and non-productive cough. Patient reports her sore throat has resolved. Patient has tried using fluticasone nasal spray and loratadine with initial relief, but states for the past 3 days she has developed new pressure and pain on the right side of the face that worsens when bending forward. Patient reports yellow nasal discharge and worsening nasal congestion. Review of symptoms is negative for fever, chills, myalgia, shortness of breath, ear pain, nausea, vomiting, and diarrhea. Denies known SARS-CoV-2 or flu exposure and denies recent travel. Patient's history is significant for intermittent palpitations and a drug allergy to penicillin with anaphylaxis in the past. Patient is up to date with COVID vaccines and the flu vaccine. Patient's vital signs are within normal limits. Patient has focal tenderness to the right maxillary sinus. She has swollen and erythematous inferior turbinates bilaterally with purulent discharge noted in the right nostril. Make sure to perform an anterior rhinoscopic exam using an otoscope and examine the septum, turbinates, and look for any pus or purulent nasal discharge. Assess for inflammation and obstruction. Be very gentle and avoid injury to any structures by orienting the speculum towards the lateral aspect of the nostril. What diagnostic testing should you perform? Point-of-care COVID-19 testing should be performed to rule out a SARS-CoV-2 infection as patient has URI symptoms. If symptoms are concerning for flu, such as myalgias and fever, or strep with Centaur criteria greater than or equal to 1, consider rapid flu or rapid strep testing. Patient has a negative rapid molecular COVID test. Radiographic imaging for symptoms of sinus infection is not recommended unless there is suspicion for a complication or alternative diagnosis. Let's look at an overview of the paranasal sinuses. The paranasal sinuses are air-filled spaces in the skull consisting of the frontal, ethmoid, sphenoid, and maxillary sinuses. Small holes connect the sinuses with the nose and allow airflow and drainage of mucus from the sinuses to the nose. When there is inflammation in the sinuses, this can cause narrowing or obstruction of the holes, resulting in mucus and pus buildup in the sinus cavities. What is an acute rhinosinusitis? In this video, I will be going over both the Infectious Disease Society of America, or IDSA, and American Academy of Otolaryngology Head and Neck Surgery, or AAO-HNS guidelines. Acute rhinosinusitis is defined by the IDSA as an inflammation in the mucosal lining of the nasal passage and paranasal sinuses lasting up to 4 weeks. The IDSA guideline recommendations are for children and adults. As per the AAO-HNS guideline, acute sinusitis is defined when there has been up to 4 weeks of cloudy or colored nasal drainage, plus one or both of the following: a stuffy, congested, or blocked nose, or pain, pressure, fullness in the face, head, or around the eyes. This guideline recommendations are for adults 18 years and older and excludes patients of any age with complicated rhinosinusitis. Overall, acute rhinosinusitis can be categorized into acute viral rhinosinusitis, AVRS, and acute bacterial rhinosinusitis, ABRS. There are non-infectious causes of rhinosinusitis such as allergies. Acute viral sinusitis is likely when the symptoms have lasted less than 10 days and are not getting worse. Acute bacterial sinusitis is likely when upper respiratory symptoms do not improve at all within 10 days of getting sick, or symptoms have worsened within 10 days after beginning to get better. IDSA guidelines identify bacterial sinusitis when symptoms are persistent for 10 days or more without any evidence of clinical improvement, or there is onset with severe symptoms or signs of high fever, temperature of 102 degrees Fahrenheit or higher, and purulent nasal discharge or facial pain lasting for at least 3 to 4 consecutive days at the beginning of illness. Lastly, the onset with worsening symptoms or signs characterized by the new onset of fever, headache, or increase in nasal discharge following a viral upper respiratory infection that lasted 5 to 6 days and were initially improving. What organisms cause acute rhinosinusitis? Most common viral causes include rhinovirus, parainfluenza virus, and influenza virus. Bacterial causes include Streptococcus pneumoniae, Haemophilus influenzae, Moraxella catarrhalis, Staphylococcus aureus, and Streptococcus pyogenes in the order of descending incidence. What treatment is recommended for acute viral uncomplicated rhinosinusitis? Symptomatic treatment is recommended when presentation is consistent with the viral acute rhinosinusitis. These adjuvant treatments can also be used for ABRS. Acetaminophen or ibuprofen can be used for pain and fever. Saline irrigation with physiologic or hypertonic saline can help alleviate symptoms and help clear mucus. Remember to use only sterile or bottled water to prevent potential amoebic encephalitis from tap water use. Nasal steroid sprays such as fluticasone can help reduce symptoms after 15 days of use, but the benefit is small. Nasal steroid sprays may cause epistaxis, headache, or dry nose. Decongestants may provide benefit with congestion and ear pressure, but avoid in patients with angle closure glaucoma, hypertension, and cardiovascular disease. Intranasal decongestants should not be used for more than 3 days in a row to avoid rebound congestion. Ipratropium bromide intranasal sprays may be beneficial for rhinorrhea, but not so much for nasal congestion. Antihistamines should be avoided as they may cause overdrying of the mucosa, causing worsening discomfort. IDSA does not recommend topical or oral decongestants and antihistamines as adjunctive treatment. Oral steroids are not recommended for routine use due to potential side effects. What is the recommended treatment for acute bacterial rhinosinusitis? AAO-HNS guidelines recommend both watchful waiting and antibiotic therapy once ABRS is suspected. As most individuals will improve on their own, delaying antibiotic treatment in immunocompetent patients for up to 7 days after diagnosis to see if there is clinical improvement can help limit unnecessary antibiotic prescriptions. If follow-up is not possible, empiric treatment can be initiated. The recommended first-line antibiotic is amoxicillin with or without clavulanate for 5 to 10 days in adults. Shorter courses may be equally effective, therefore a 5 to 7 day course is recommended. If penicillin allergic, doxycycline or a respiratory fluoroquinolone such as levofloxacin can be used as first-line in adults. Avoid ciprofloxacin as it has limited antimicrobial activity against Streptococcus pneumoniae. IDSA guidelines recommend antibiotic treatment once a clinical diagnosis of ABRS is established. Amoxicillin clavulanate is recommended as a first line in children and adults due to the high prevalence of beta-lactamase producing respiratory pathogens, H. influenzae and M. catarrhalis. Doxycycline is recommended as an alternative when amoxicillin clavulanate cannot be used in adults. For non-type 1 penicillin allergic patients, a third-generation cephalosporin, cefixime, cefpodoxime, with or without clindamycin can be used. Empiric monotherapy is no longer recommended with cephalosporins. When a type 1 penicillin allergy anaphylaxis is present, levofloxacin can be used in children. The recommended duration of treatment in adults is 5 to 7 days, whereas in children it is 10 to 14 days. Macrolides such as azithromycin and clarithromycin have a high Streptococcus pneumonia resistance rate of approximately 30% and is not recommended as a second-line treatment. TMPSMX has a high rate of strep pneumo and H. influenzae resistance, approximately 30 to 40%, and is not recommended as a second-line treatment. A word on antibiotic stewardship. Most acute rhinosinusitis infections are associated with a viral etiology, and it is estimated that only 0.5 to 2% of adult cases are caused by a secondary bacterial infection. Approximately 86% of U.S. ambulatory visits for acute sinusitis results in an antibiotic prescription. Sinusitis is the fifth most common diagnosis for which antibiotic is prescribed. Practicing antibiotic stewardship and evidence-based medicine improves overall quality of care and helps in the fight against antimicrobial resistance. In our patient, she has colored nasal drainage, nasal congestion, pain and pressure in the face. The symptoms have worsened within 10 days after beginning to improve and meets both the AAO-HNS criteria and IDSA guideline for an ABRS. Because the patient has a type 1 mediated penicillin allergy anaphylaxis, doxycycline for 5 days will be an appropriate first-line treatment along with continued nasal fluticasone use, saline irrigation, and ibuprofen as needed for pain. Oral decongestant is not recommended as the patient has a history of palpitations. Patient is advised to discontinue loratadine as it may contribute to excessive dryness and worsening discomfort. So you may be asking, which guideline do I use, the IDSA or the AAO-HNS? The IDSA guideline was published in 2012 and the AAO-HNS guideline was published in 2015. I went over both to show the importance of staying up to date with evidence-based medicine and guidelines, as recommendations may vary. I recommend the AAO-HNS guideline as it is more recent. Follow-up. If symptoms worsen or fail to improve on 7 days of initial treatment, patients should be reassessed to confirm the diagnosis of an uncomplicated ABRS. If confirmed, an alternative antibiotic should be used. A complicated ABRS indicates that the infection has spread beyond the paranasal sinuses. This can result in meningeal signs, severe headache, vision changes, altered mental status, abnormal extraocular movements, periorbital edema, or persistent fevers over 102 degrees Fahrenheit. These individuals should be referred urgently for further evaluation. That's it for today. Thank you for watching Dr. Pearlz Clinical Rounds. Don't forget to hit the like and subscribe button if you enjoyed the video. Let's move on to the next case.